I'm Konstantinos Drosatos. I'm the Ohio Eminent Scholar and Professor in the Department of Pharmacology, Physiology, and Neurobiology at the University of Cincinnati. We're very pleased today to have a young star in cardiovascular metabolism, Dr. Anja Karlstaed from Cedars-Sinai Medical Center, who will tell us about a new study that is presented at the American Heart Association Basic Cardiovascular Sciences Conference, and it will also soon be published in Circulation. Anja, welcome, and thank you for being with us. So your study is about an enzyme, which is called ATP-dependent citrate lyase, and you show the importance of this enzyme for maintaining cardiac function, or in other words, when this enzyme is suppressed, leading to heart failure. Do you want to tell us a little bit more about what this enzyme does and how it came in your life?
Yeah, it's a very good question. So, like you said, it's the ATP-dependent citrate lyase is a very long name. So we usually call it ACL. And it's, as the name implies, it's ATP dependent, and it converts citrate to oxaloacetate and acetyl-CoA. And so this is an enzyme that appears in every cell in your body, and it's essentially responsible for synthesizing precursors that we need to make fatty acids. And we stumbled upon ACL when we were studying actually a completely different mechanism in the heart, where oncometabolites that are produced by cancer cells are sort of disrupting mitochondrial function in cardiomyocytes. And then suddenly ACL was upregulated. And in our study, in order for the heart to overcome this oncometabolic stress, the heart was upregulating this specific enzyme, and we saw more acetyl-CoA, we saw changes sort of in the genome, and we really wondered, like, why does this enzyme suddenly play this important role? And we started studying it further because there is a little bit this dogma in the field that the heart actually doesn't do any de novo synthesis of fatty acids, and it usually takes it up from the blood and then can incorporate it into their membranes. And our study was essentially implying that in certain circumstances, the heart is starting to use this particular enzyme. And so we started studying it further.
Yeah, that's great. That's great. So what is the association with heart failure? I mean, this is an enzyme that's supposed to have beneficial function for the heart. And you showed nicely in your study that in heart failure, it is suppressed. The expression of the enzyme is suppressed. It's going down.
Correct.
So one question, because we're trying to understand heart failure, but we also try to cure heart failure. So how do you envision this as a therapeutic target for an intervention that will alleviate the symptoms of heart failure?
Yeah, that's a very good question. It's actually a little bit more complicated than we also thought with our studies. We need to distinguish different types of heart failure. In the context of our cancer studies, we noticed that ACL is upregulated, and it becomes sort of this overcompensation of a system. And then in other circumstances, like in conditions where we observe mostly hemodynamic stress and heart failure with reduced ejection fraction and also preserved ejection fraction, then suddenly ACLY is downregulated, and it becomes sort of a way of redirecting citrate into other pathways. And in our study, we show that this redirection also requires more energy. Actually, our cardiomyocytes are then starting to use another enzyme, which is the isocitrate dehydrogenase 1, which is in the cytosol, and it requires NADPH. And with that sort of shift in redox state, the lack of ACLY becomes actually more energy consuming and less beneficial. So that adaptation becomes suddenly a maladaptation. And the way we're envisioning this is that we need to risk stratify our patients. We need to understand essentially where are they with their ACL sort of level. Are they upregulating ACL? So are they compensating because there's suddenly more citrate and they need to kind of shuttle it into acetyl-CoA, or do they indeed do lipid remodeling, or are they already experiencing a disruption of this enzyme through other causes, and it creates now this sort of maladaptation into other pathways. And there are certain drugs available that are directly targeting ACL because we all know high levels of fat are not that beneficial. They're associated with a lot of cardiovascular diseases, and similar in tumors, ACL is a target because the tumors need to proliferate and they need to generate more membranes, and targeting these de novo synthesis pathways can be a benefit. But if you now have a patient that is downregulating ACL because citrate needed to be redirected, then further downregulating ACLY could actually exacerbate cardiac stress and further drive this patient into a heart failure phenotype. While on the other hand, in the context of our previous study where we saw an upregulation of ACL, then suddenly this strategy could become beneficial. And so we're actually showing that metabolism is very complicated, context dependent, and we cannot just take this blanket statement for all of our heart failure patients. We really need to look at where are they, and then basically meet them where they are, and then design a therapy that actually benefits them best based on the metabolic profile.
So you touch upon a very important matter that our field now is expanding to, which is cardio-oncology.
Yes.
So a lot of therapies, a lot of treatments that are used for patients with cancer have some sort of what we call cardiotoxicity, aggravating effects in cardiac function. So do you think that the ACL is like a nodal enzyme that you need to maintain at a certain level of activity so that you, at the same time, have beneficial treatments for cancer, but also protect from cardiac dysfunction?
Yeah, absolutely. And I think we need to think more about how these enzymes interact. Like our study became very complex because we noticed that ACL was the culprit of our stress that we were inducing, but it is connected with another very important enzyme, the isocitrate dehydrogenase, and all those work in synergy. And so depending on the tumor profile, basically, is this a tumor that is upregulating ACLY or is it downregulating in patients? And the cardiotoxicity that we already know that some of these drugs have, we need to then tailor the treatment options for these patients. Sometimes we can give them treatments that can further reduce ACLY. With other patients, that is not the case. And so we are right now trying also to understand ACL more in these sort of cancer-specific mechanisms. We showed previously that particularly leukemias are upregulating ACL, so there it could be beneficial. But with other tumors like solid tumors, lung tumors, colorectal cancer, we don't really see that. It doesn't change that much. So in these cases, we might actually harm the patient by targeting this as a therapeutic.
So in your study that will soon be released in Circulation, you used nicely one tool that your group has developed. It is called CardioNet. And this is something that the community needs a lot. I mean, tools that can help us process big data and understand what changes when we assess the big data sets, but at the same time, predict what may be important to target. Can you tell us more about this tool?
Thank you. Yeah, so CardioNet is a genome-scale metabolic network. It's basically a big database and a mathematic model at the same time that we can use to understand metabolism. I developed that during my PhD, and we have, in the past 10 years, tried to refine it even more and applied it to various different studies. And the model can predict fluxes in the heart. So when you can overlay it with RNA sequencing data, proteomics data, metabolomics, or any other physiological parameters that you have measured in an experiment, and then integrate them together. Very often when we do experiments, we just look at one feature at a time. And models like this can actually take them all in one big measurement and then overlay them and help us to understand in an integrative way what would be now the systems level change. And we use CardioNet both in an iterative way to understand our experiments, but then also very theoretical. And In this particular case, we integrated all our experimental data coming from carbon-13 flux data, enzymatic activities, RNA sequencing, also some protein information, and what we know about the extracellular space in our experiments. And then we ask the model, what are essentially the theoretical flux distributions in a patient that experiences a loss of ACLY versus a healthy subject? And the model identified essentially enzyme features that are differentially regulated between those two cohorts. It allowed us to identify a subset of about 20 different proteins that are primarily driving these changes between our patients. And then we simulated theoretical knockouts of these proteins in a very systematic way, and then tested, is any of these enzymes actually able to reverse and attenuate the phenotype? And that's a basically in silico way of testing potential therapeutics, identifying drug targets, but then also mechanistically explaining how a disruption in a very specific metabolic enzyme can lead to an alleviation of the phenotype. And with that experiment, we were then able to identify again that isocitrate dehydrogenase, the enzyme that I previously mentioned that is sort of redirecting citrate away from ACL and helping to compensate, was one of the maladaptive responses, because it was taking away suddenly redox components from the glycolysis and actually not improving cardiac energy efficiency. And by testing this theoretical, we could show that by knocking out IDH1 or reducing its enzyme activity, we could actually boost energy provision. And we then went back into our experiments and knocked out IDH in an in vivo mouse model and could basically validate these computational simulations. And we aim to advance CardioNet actually further so that the community can use it with their own data and apply it to their studies. But it is also, I hope, a good workflow for other groups to theoretically identify potential new targets whenever they are disrupting a metabolic enzyme or protein.
This is great. So you mentioned that you started developing this tool when you were a PhD student.
Correct.
We both know that the American Heart Association pays a lot of attention in supporting young investigators and fostering the development of their careers. To close the discussion, what would you like to give us an advice? You are a young person, you are an early stage to mid-stage investigator. What would you advise someone who starts today working in cardiovascular metabolism as a PhD student? What would be the first advice you would give to this person?
Oh, the first advice, I think it would be keep an open mind and be open to new technologies. Embrace them, be critical about them, but also try to understand what are sort of their benefits and their limitations, because they can help us a lot in our day-to-day work. Like, I didn't know how to do programming. I needed it for my studies. And so don't be afraid if you're essentially faced with an obstacle, a new challenge. Embrace these technologies and then use them for your questions that you're trying to answer. And so, yeah, I think that would be my advice.
Okay, thank you very much, Anja.
Thank you, Konstantinos.
It was great to have you here today and share your experience in science and also give us some input about the upcoming study of your group. And if I may, because you have trained with the person whom we all admire, Heinrich Meyer, I would like to close the discussion with his favorite quote, which is "Long live metabolism." Thank you very much.
Thank you so much.